Every newborn deserves the best start to life. However, in Uganda, despite more births occurring in health facilities, many still don't survive past their first month of life. According to the Uganda Demographic and Health Survey, 22 newborns die every 1,000 live births. Each loss represents a family shattered, a system failing its most vulnerable citizens, and a reality we must confront. Despite national efforts, newborn deaths continue to account for nearly half of under 5 deaths in Uganda. To reduce the alarming rate of newborn deaths and improve care for 120,000 small and sick borns, a coalition of partnerships, namely Makerere University School of Public Health, Baylor Foundation Uganda, Adara Development Uganda, Nsambya Hospital and Ministry of Health, with support from ELMA Philanthropies, launched the Uganda Newborn Programme in 2022.
So the Uganda Newborn Programme is work that building on a lot of work we've been doing over the last almost one and a half decades. The background is, as you know, we are just a few years to the end of the SDGs, or the Sustainable Development Goals. But the target is ambitious, and yet Uganda is not doing very well. We've improved a bit, but still lots to be done. The approach that we are taking builds on evidence we generated in Eastern Uganda with support of ELMA Philanthropies and others, which show that one of the best ways to effectively scale up and do sustainable maternal newborn care is to use a regional approach. In the regional approach, you map all the facilities that are within the network, and you don't improve in one facility only, but you do improvement across the different facilities in the region. The idea is that if every facility is improved, then referral becomes easier, but also management of mothers and newborn within the network.
Under this program, huge strides have been made in 20 high-burden districts and 36 health facilities across Western, Kampala, and North Central regions of Uganda.
We've seen tremendous achievements. We've seen with these NICUs that have been constructed, with supporting the staff, with supporting the districts with the supplies, we've seen an increasing number of newborn admissions in the newborn care units. From the previous quarters, we've seen a large number of admissions, and actually we've seen these babies survive. Over 90% of these babies that are admitted in the newborn care units, they have survived, and that's the goal of this project. We've seen an improvement of staff utilizing the data in the newborn care units, and we think with increased support, they will actually go a long way to improve the management and improve and reducing the mortality in the both regions, in Rwenzori and Bunyoro. We had around 60 mothers and babies who were transferred with very good outcomes. From the time of inception of this project, we've been carrying out mentorships for the staff that work in maternity and newborn care units. Those are the nurses and the doctors. And we've actually mentored these staff in the neuroresuscitation and emergency obstetrics, that is how to do cesarean section, how to manage preeclampsia, how to manage PPH, and we've seen knowledge of this staff above 80%.
Yes, we have seen some improvement in the survival rates because the lowest birth weight we have managed in this facility. We have managed the 900 grams baby, and it survived. We followed up the baby and we got good outcome. The baby is okay and currently alive. The previous quarter, that is October, November, December, we had 69 admissions. Out of the 69 admissions in that quarter, we had one death, only one death.
We had been stagnant for almost 20 years at 27 deaths per 1,000 live births. But in 2022, the last situation analysis, we went to 22 per 1,000 live births.
In addition to revamping many newborn care units, the program has supported construction of newborn care units in Kyegegwa, Bulisa, Masindi Hospital and Kyangwali Health Center 4, among others. Another innovation that has been scaled up through the program is the home-to-hospital model aimed at supporting mothers and their newborn babies after hospital discharge.
The hospital-to-home program is designed to help the high-risk infants in the hospital and after discharge home. The goal of the H2H program is to help them survive and thrive through follow-up. The mothers are visited on scheduled visits and at 6 months, and then at 9 and 12 months, these community health workers go back and visit these babies to identify the developmental milestones.
She gave birth to the twins, a boy and a girl, that is Kato and Babiji. They were born at 8 months and they were taken to NICU. They were nursed there and she was discharged. Kato had 1.7 kilograms, Babiri had 1.8 kilograms. So they were very tiny, they were very small, and the mother had to get someone to help her to know how to deal with those small babies, because first they were small, second they were premature. So she had to get some other information, some knowledge, some guidance on how to nurse the baby and to gain some weight. So that is how I came in to support the mother.
Ndabanga abaana batandise okuvaamu, kilo zeeyongeddeko, mpulira ng'essanyu kubanga bakoze eki okusinziira we baali na kati we batuuse, mpulira nga kimpa essanyu. Era nembanga neebaza nnyo ekitongole kya Adara wamu ne VHT, mbeebaza nnyo mwebale.
We've also seen improved vaccinations, because when these VHTs go to their homes, they're able to remind them of the vaccination of their babies, and we've seen an improvement in the vaccination rates for these young babies. We have also seen that our babies are surviving and thriving because VHTs keep following up these very sick babies while at home and reminding the mothers who have sick babies to refer to the nearest health facility so that a baby does not die of a preventable disease that can be handled at lower health facilities.
Still under this program, the first ever milk bank was established at Nsambya.
ELMA has done a great job. We already have now a human milk bank. Over 200 babies have benefited from this. We have over 400 litres that have been collected, and we are hoping to scale up this thing to other hospitals. Many of the mothers now, when they are struggling with breast milk, we have a bank and we also have workers who work there. They come from the NICU and they go to the bank where the lactation nurses can assist them to produce enough milk. So really ELMA has done a big job in improving the survival of these babies by ensuring that we have adequate milk, because milk saves lives amongst these babies.
To inform policy and practice around newborn health, the program through its partners also produced a situation analysis of the National Newborn Health in Uganda Report 2023. This document, last produced 17 years ago, has been adopted by the Ministry of Health to improve newborn health outcomes. Despite the many program achievements, some challenges persist, including unstable power supply, insufficient drug supplies, low quality of data, and internal rotation of already trained nurses, among others.
The biggest challenge that we've faced is basically the human resource challenges. There are still very few human resource, the nurses, the doctors, and the specialists in these newborn care units, supporting the newborn care units. You'll find there is one NICU staff who has to manage over 50 babies in a month.
Under this program, valuable lessons have been learned.
So the main lesson is that we've learned, one is the importance of co-designing. Here we mean that you don't sit in your boardroom and design a program, but you go out to the stakeholders, namely the Ministry of Health, but also the districts and the facilities, and you design the program together, and you make sure that the program is aligned to the structure and systems, but also the existing capacity. The second one, we've seen that using a regional approach actually leads to rapid and more sustainable scale-up of newborn care.
I do recommend, because it has brought success to the region, and we have seen referrals reduce. Initially we would have very many sick babies, those with basic conditions and those who are very sick, but now we've seen reduced referrals. The facilities in Luweero and Nakaseke are able to take care of their babies but refer the very sick newborns to Chiwoko, which we feel has worked for the region.
What I've learned from this project that I've been working on with the increased one, staff placement, building the newborn care units, and having the surprise in place would go a long way to improve the newborn care in the region and the Uganda at large.
Currently, we're just focusing on survival in the first month after birth. But you know, some babies are right now already 1 year. If they were born preterm and they were in hospital, what is their current, what are they alive? And are they thriving? Are they doing well? Is there more care that is needed? What is the cost? How can parents be supported? And how can we make this to be more integrated? And how can we make this to be more sustainable? All this research we need to do. And that calls for government investment.
What I recommend that the Ministry of Health, the government of Uganda should continue to support the health facilities and the districts, make sure that the staffs and they are placed to these facilities, and also make sure that the medical officers and actually do support these units.
We acknowledge first the families that have these babies, and then the hospitals and health centers and districts that we work with. Then also the partners that who are already involved in implementation, such as Adara and Baylor College, but also the funders, which is mainly the ELMA Philanthropies, and also the Ministry of Health and its partners like WHO, UNICEF, and others.